This episode of the Bari Chronicles is proudly brought to you by Bariatric Support Australia.
So I'm Wendy Brown. I'm a surgeon based in Melbourne. I do both upper GI and metabolic bariatric surgery. And I was fortunate enough to be a member of the Lancet Commission, which were tasked with coming up with a definition for the diagnostic criteria of what we're calling clinical obesity. So the Lancet is one of the biggest medical journals. It's probably one of the most important medical journals. And we say it has a high impact because that just means lots of medical practitioners around the world read it. And usually the very highest quality research gets published in journals like the Lancet. And over the years, the Lancet has sort of developed, I guess, an interest in creating conversations in areas of controversy. And I think a lot of what they're looking for is to start conversations amongst not just clinicians, but also other researchers, people that work in a field, and importantly with consumers about key areas. And one of the areas that they focused on recently was obesity. The controversy, I guess, they're thinking about is BMI enough? You know, if you take your BMI, which is your weight in kilograms divided by your height in metres squared, traditionally, since the 1950s, we've said once that number hits 30, then you're diagnosed with obesity or you are considered obese. And there's been a number of quite august health organisations that have come out saying, well, that obesity is a disease, and therefore if your BMI is 30, you have the disease called obesity. And I guess there's been some pushback from that, particularly from people living with obesity saying, well, hang on, my BMI is 30, but I'm an athlete and I'm not sick. Or hang on, my BMI is 30, but I'm perfectly happy, physically fit, my blood tests are perfect. So, how can you label me with a disease? So the Lancet picked up on this and sort of tasked a group of 54 people from around the world to come up with a better way of diagnosing obesity or framing obesity in such a way that it's more useful in a clinical context and, I guess, most importantly, most useful for people who are living with higher BMIs. So there was 54 commissioners.
That's a lot of people.
A lot of people from all over the world. It was led by one of my friends, Francesco Rubino. He's a professor of surgery at King's College in London. And the commissioners included basic scientists, nurses, people who study population health, epidemiologists. And everyone knows what an epidemiologist is now that we've had COVID.
Yes.
As well as, people like myself who practice clinically in the field of obesity treatment, so surgeons and physicians. And there were 4 commissioners from Australia, so Priya Sumitran, who works with me, Louise Bow from University of Sydney, and John Dixon, who is also here in Victoria at Swinburne University. So we were really fortunate to be chosen. But the other commissioners came from a range of settings, like people from emerging economies, people from, very august organisations like Harvard, and people from, community colleges. So they really tried to get people that represented broadly I guess the views of not just people sitting in Europe or people sitting in Australia, but around the world. And I think there were people with lived experience involved. And then there was also a long period of consultation once the document was developed, where it went out for consultation, and quite significant review by all those different organisations. And one of the person who was the peer reviewers was someone with lived experience who had quite significant contribution into sort of changing some of the wording and how things were done. So when journals publish it, or when journals publish things, they don't just accept what people have put in. They get critiqued quite strongly before they publish it, and they followed exactly the same process for this, even though it was a report that they, I guess, commissioned. So it was a big group of people. We met every couple of months over a 2-year period.
Wow.
We didn't always agree, and even at the end, I'm not sure everyone totally agrees with everything, but I think what everyone does agree with is that we need something more than the BMI so that we can provide a more nuanced approach to each of our patients who we see when we think about weight as potentially something that could be exacerbating or causing not just ill health, but a sense of lack of well-being and other I guess the 2 major things we came up with was that firstly, when we measure people, is that we shouldn't just use the BMI, which is your height, as I said, in metres, your weight in kilograms over your height in metres squared. We should augment the BMI with questions around what is the quality of the weight that's being carried, and also where is the weight being carried. So by quality, I mean protein is the high quality sort of tissue that we look for. Like if we were all ripped and, had lots of, very lean muscle mass, we'd all be, 100% happy with that. But so what I mean by that, I guess, is if you came in to see me and your BMI was 31 and you're an NRL footballer, and you were just totally solid muscle, labelling you with a term like that you're living with obesity is probably inaccurate, and it's over-diagnosing a condition. So
potentially offensive.
Potentially for some people. Unfortunately, we still live in a world where there's a lot of stigma around the word obesity, so it can create rifts in therapeutic relationships between doctors and patients rather than, enhancing the opportunities to look at ways people can improve their health. The Commission is not saying we should throw the BMI out. We just need to contextualise it and say, well, look, if your BMI is high, why is it high? What is the tissue you're carrying that makes it high? And if when you assess the patient, it turns out that is muscle, then obviously that's a very different answer than then if you say, look, actually it looks like you're carrying extra fat tissue.
Yeah, definitely.
And even if it is fatty tissue, that fatty tissue can be sitting in your body quite happily, causing no ill effect. And particularly if you carry your weight around your hips or the thighs, like a lot of us women do, it's well away from your vital organs and quite often has no effect at all on your sense of health or your sense of well-being. And so the Commission was suggesting that not just looking at BMI and saying, well, what is the weight you're carrying, but then, well, if it is extra fat you're carrying, where are you carrying it? And there's a simple way we can assess that, and that's just by measuring you around your waist. And if your waist is more than 1 metre for a man and more than 88 centimetres for a woman, it's likely that you're carrying weight around your middle, and carrying weight around your middle means it's closer to your vital organs and your heart and your lungs. And we also know it's more likely to be associated with the diseases that often go along with obesity. So the Commission was suggesting that, first of all, you sort of assess your patient, see what's the quality of the extra weight or the type of tissue that's creating the extra weight. And then secondly, if it is extra fatty tissue, where's it being carried? And they're suggesting that you can do that by measuring the waist. Even better, you can measure also the hips and do a waist-to-hip ratio, which sort of tells you, are you someone who's got a sort of a round shape or a pear shape? But that, they're things that can be relatively simply done in the consulting rooms. And that can be done in any healthcare setting, from emerging economies through to the very fanciest sort of clinic. Obviously, if you had access to something like one of those scales that tells you what percentage you are of muscle and what percentage you are fat, that would be even more ideal. And if you had opportunity to have like a DEXA scan, which is an X-ray that even more accurately tells you what your body is made up of or your body composition, then that would be ideal too. But the Commission accepted that those kind of tests and those kind of equipment are often expensive and possibly not always accessible to your everyday practitioner and to everyday people that might not have the extra money to pay for those tests. The other thing that the Commission was recommending is that we don't necessarily use a cutoff of 30 as a hard and fast rule for obesity. For some time now, we've been saying a BMI of 27.5 for people of Asian populations. You could start to think about obesity because we know in Asian populations that the diseases related to obesity do start to kick in. But there are people who have BMIs even in the so-called normal weight range of a BMI of 20 to 25. And I say normal because it's not actually normal in our community, but in that BMI of 20 to 25 range, who do have a very broad waist and narrow hips and do have diseases that could benefit from loss of fatty tissue. So, there's a risk if we use a number that we can also underdiagnose people, or we could ignore the fact that there's opportunities for people who are even, maybe you'd look at and say, oh, you're just a bit chubby around the middle. There's still opportunity for them to maybe improve their health by seeking ways to lose that fatty tissue. So with the Commission, I think the first thing they really did was say a BMI is not enough. We need to think about, what sort of weight you're carrying, where you're carrying it, and what that means to your health and well-being. And in some people, we don't even think you need to have a BMI measure. If you've got a waist to height or a waist to hip ratio that suggests that you're carrying weight in an unhealthy place, then that's enough to say that this is someone who's worth it. It's really good to explore with them about what options they may have for trying to reduce the amount of fatty tissue that they're carrying. the second step was, not just sort of diagnosing, I suppose, or having a way of measuring. And I suppose saying diagnosing is like, when we're doctors, we like to have a way of objectively documenting what the issue is that a person's got. So, we like to take your blood pressure, or we like to take your pulse rate. So now we're saying, well, this is how we take your obesity, so to speak, or how we measure or test for whether or not excess fatty tissue is a problem for you. Just to measure it, you then have to talk to your patient and find out what that extra fatty tissue might actually mean to them. And as I alluded to before, it may be that it is nothing, that they're absolutely fine, that they're functioning in their job, in their family, in society, that they're happy, they're healthy, and they've got really no desire to, no need to change their weight. And if that's the case, then that would put us in a bit of a sort of wait and watch type category, and just, informing people about what the potential risk could be in the future. A bit like if you came in and your blood sugar level was just a little bit under the threshold for diabetes, or your blood pressure had just started to creep up a bit, or your cholesterol had just started to creep up a bit. Your doctor might just say to you, look, this is just something we want to watch. But in the meantime, eat healthily, exercise, do all the things you can do to stop it from getting worse. But if we do talk to people and find out, well, yes, it is impacting on my happiness, it is impacting my relationships, it is impacting my ability to do my job, or, I am feeling tired or run down. And if we do the blood test to look for the different conditions that can be associated with obesity, then that's a time that we'd say, well, you probably have what we would call clinical obesity. So this is obesity that is impacting on you in some way that's clinically important and importantly important to the individual. And that's when you start to have different conversations about what are the different options that we have available to help you lose some fatty tissue, manage your weight, and achieve the goals that are important to you. It opens up conversations, I think that are really important, and it really introduces strongly the concept of personalised medicine, that we're not just lumping everyone under one umbrella. Gosh, you've got a BMI of 30, therefore you have a disease called obesity, to, hey, you're probably carrying excess fatty tissue. It may or may not be reflected in your BMI, but it's reflected in other ways, and there is a chance that we could make your life healthier and better if we help you to lose some of that fatty tissue. Or, hey, you're on the edge of this maybe being a problem in the future. Just be aware of it. Here are some measures you can take to ensure that you continue to stay feeling healthy and active, without going away with the label of clinical obesity. And we're calling that preclinical obesity, and that's more just for medical terms, a bit like pre-diabetes or pre-blood pressure, or, other things that we talk about. So, I don't know that this is the perfect solution, but it was the best thing that 54 people could come up with that was sort of acceptable across the world. It's certainly a great conversation starter. And if all it does is start people to think about it, people to start to talk about it, then all that can do is stimulate more studies and more discussion. And I'm sure with time there'll be refinement and these measures will change as we start to put them into practice, because these are not practice guidelines. They're just, suggestions for how we can look at reframing our approach as doctors to people who are carrying excess fatty tissue. And they'll need to be translated by the professional societies into things that are pragmatic and useful in different healthcare settings. But
so how does that process work?
So it's a little bit different in every setting, but the general process is that the guidelines or the Commission's recommendations were circulated broadly, and so far about 75 medical organisations across the world have endorsed them and said, look, we think it's a good starting point. Excellent. And that they're keen to look at them. And so what we hope the next step will be is that people who live and work in the countries, like people who, like myself, I suppose, will start to try to have conversations locally with our own groups about how this could influence the way we practice. We are having a webinar on the 5th of February, which is sort of an Asia-Pacific launch around how can we use these in the Asia-Pacific more specifically, and who can we reach out to work with to see can they be useful, can they be incorporated into guidelines. In Australia, unfortunately, timing-wise, the NHMRC are just finalising some new practice guidelines for obesity They're in the sort of final throes of that now,
Right.
whether or not it's too late to incorporate it. But look, I think all these guidelines and things in the past used to last us for 10 years. But, luckily at the moment, the options for treating obesity are just rapidly expanding, and it's a very always changing field. And so we need to be a bit more adaptive and be able to be a bit more iterative, or as we used to say in the pandemic, pivot as new things come out. And so, hopefully there'll be opportunities there. But, people like Louise Bauer, who was the head of the World Obesity Federation, and John Dixon is, I think, the vice chair of NACOS at the moment. They're both very connected to the College of Physicians, College of General Practitioners. Priya's very connected through the Endocrine Society. I guess I'm more in the Obesity Surgery Society space, but, work with the organisations to help get the message out there. Hopefully we'll start to see this creep into the way we teach at medical schools and just change things from the grassroots up.
I think it's great because so often we have people who say to us, the scales haven't moved, but I'm feeling so much better, but my doctor is disappointed. I think it gives another point of reference that the metabolic health improving. It really doesn't matter what the scales say or what your BMI is. If your internal health is getting better and you're feeling better, then I think that's a great way for people to actually be heard.
Yeah, I totally agree. I mean, I see that with my own patients a lot, especially people who've really gotten into exercise and they're really, changing things up. And the reality is their body composition is changing. So they feel better, their clothes, they're going down clothes size, but the scales isn't shifting, and they get really disappointed. And I'm like, well, let's measure your waist. And you can see them waist has gone down 10 centimetres. And that's massive for your metabolic health to lose that much weight from around your waist. And so, while scales are helpful because, we like to be accountable, we like to see where we're progressing. Sometimes for some people, scales are not the right measure. It really is things like your waist circumference that is much more important. I always remind my patients, if you look at a kilo of very lean beef or 500 grams of very lean beef, it's quite a small, compact unit, whereas a kilo of fatty mince is much bigger. So, as you get rid of the fat, your size will come down, but your weight may stay the same as you build up your muscle and lose the fat. So again, I think this is just re-emphasising that we need to be a bit more nuanced than just weighing people. We need to be looking at what's the quality of the weight they're carrying and where are they carrying it. And as you say, if they're seeing their diabetes get better, if they're seeing their blood pressure come down, if they're seeing that they can do up their shoelaces and can go to the gym and can walk on the treadmill, if they can be out and active with their kids and their friends and be productive, then it doesn't really matter what the kilos say or the BMI says.
Job done. Quality of life and being able to live a full life is the end goal of all of this. So it's exciting to think that people will be able to, hopefully in time, sit in front of their lovely GP and expect that it will be a conversation that is more about how they feel within themselves, as well as the other diagnostic criteria, and not just about a number.
Yeah. And look, there are sort of 18 diagnostic criteria that the Commission came up with. So, combining the measurements then with a number of things.
That's a lot of numbers.
It's a lot of numbers, and I can't, to be very honest with you, I would have to look up the list. But they're things like, your sense of well-being, your joint pain, whether or not you're short of breath when you exercise, sleep apnea, polycystic ovary syndrome, so things that you would expect. One thing that I found a little bit harder to agree with, but obviously it's a consensus view, is they decided diabetes wasn't a diagnostic criteria because they felt diabetes is a sort of standalone disease on its own. But I think in practice, people will look at, it's about metabolic health, as you say, Damo, and I think, we'll see diabetes, definitely those two things. If you happen to be carrying weight and diabetic, we just see that diabetes the control gets so much better when people are able to lose some weight. So they do go hand in hand a little bit.
Yeah, I guess that's what my lived experience was, going from being, dependent on 350 units of insulin a day. And after I lost about 50 kilos, the type 2 was in remission, or whatever anyone wants to call it. And I wasn't on any medications. And
the only thing that changed was the amount of weight.
fat that I was carrying. I think for people that are actually speaking from their own lived experience, even though it might not necessarily line up with what some of the doctors say it should, I think it's good when they can actually take the voice of people that are actually living with it and going, you know what, this is helping me.
Yeah. And look, we're just publishing a paper from our registry, the Australian New Zealand Bariatric Surgery Registry, and at 5 years, we're seeing, 61% of people who had diabetes at the time of their bariatric surgery they don't need any other treatment for their diabetes.
Yeah. Fantastic stuff.
Which is amazing. And it's a community level study. Now, we don't get 100% follow-up of people, but, from the best we can tell, it's a fairly representative sample that we got the information from. But it just shows, I guess, the power of what you've lived. If we can help people to manage their weight, they're not just managing their weight, they're improving a lot of other conditions that kind of are exacerbated by the weight or are caused by the weight.
Yeah, I think back to I was on a public waiting list for some skin removal, and from when I got on the list to when they rang me to say you can come and have your surgery was about 2.5 years. And I'd put on one BMI point and they wouldn't do the surgery because of that one BMI point. And I said to them that, I'm active, I'm out, I'm building muscle. No, it goes on your BMI, you're 1 point over, we're not doing it. And I lost my place on the list. And, after 2.5 years of...
And you still haven't had that particular
And I still haven't been able to have that surgery. So I look at this and I think this can be life-changing when people can actually take this information and advocate for themselves and go, okay, well, the numbers might say this, but what is everything else saying about my health? And just because my BMI might be up a little bit doesn't mean that I'm unhealthy and I'm going to die on an operating table.
And it could be that you'd, weigh on a different scale and you'd be 1 BMI less. It's a fairly imperfect measure. And, the Commission makes this point that there has been, I guess, discrimination against people on the basis of BMI and lack of access to healthcare. And we do see that, throughout, I guess, public hospitals or hospitals in general make rules to try to optimise safety for patients. So certain facilities will say, look, we don't think we can cope with people over whatever BMI. But again, they're sometimes creating problems for people that creating barriers to people that otherwise are very healthy and could quite safely have their care at a facility that doesn't need all the other bells and whistles.
So as far as the redefinition of obesity, I suppose, as you've already said, it's up to the different organisations and how they will, what the uptake of these guidelines will be. But in a perfect world, what kind of changes do we think it could make to the way that a person like me or Damo would experience a doctor's visit?
Well, hopefully, I hope that, it becomes just as normal as your doctor taking your blood pressure and your pulse, that they also weigh you and take your height and then measure your waist. Now, if they've also got the scales that spit out the body composition, then even better. But they are quite expensive technology and, not everyone has that. But it wasn't that long ago that GPs didn't even necessarily have scales in their practices that would weigh above 180 kilograms or 120 kilograms because standard scales used to just go to 120 kilograms or maybe 180 if you were lucky. So the ability to have a set of scales that goes as high as they need to go in every practice.
Yes.
Measuring people just as matter-of-factly as you take their blood pressure and with the same lack of judgment that you have when you take someone's blood pressure and find it's higher than you'd like it to be. We should be able to then have a very frank conversation about how is this affecting you and without stigma or without fear of, any kind of healthcare bias, be able to then discuss what options might be. So I hope this is a step towards normalising, diagnosing people where weight is an issue for them in a little bit more of a less stigmatised way and in a more routine way, if that makes sense, and just makes it a normal part of everyday life that you can expect that your healthcare practitioner will talk to you about.
Yeah,
this.
I mean, this was actually another question that I had for you because I believe that I believe that our GPs, our surgeons, our health professionals are people that so many of us that have been living with clinical obesity or living in bigger bodies. We go to these people, we look up to them, we're wanting help. And I think sometimes in the past, I've definitely experienced stigmatising comments, conversations from providers. What role do you think healthcare providers actually play in addressing the stigma that exists in society? Do you think that there's more that could be done?
I think, it's well demonstrated that, most people living with obesity will feel that they've been stigmatised or that somehow and it's quite demonstrable that their healthcare is possibly being compromised because people have assumptions around obesity, and those assumptions are out of date and they're inaccurate. It's up to each of us as healthcare practitioners to treat our patients without bias and without judgment. It's part of the oath we take when we start that we'll care for our patients no matter where they come from or what they do. And I think that if we can change it, the way to change it really is, I guess one patient at a time. In a way, it has to be a bit of a grassroots change from medical school and nursing school and dietetic school and, wherever it is we're learning about how we care for patients in the future, that they understand this is obesity occurs because of physiological imbalances or because of the way people's metabolisms are. The inability to lose weight is very normal. 7% of people struggle to lose weight. There's multifactorial things that lead to this, and it's not just someone not being strong enough to eat less and exercise more. It's far more nuanced and complex than that. So we need to be getting that message through right from the early stages. And we need to also then start to shift community understanding as well, because I think sometimes the conversations with doctors are hard because the people themselves don't like having the conversations. So we need to start getting the community to understand that obesity is something that is really difficult to manage. It's a difficult problem. We'd love to prevent it. We haven't. For a lot of people, we haven't prevented it at all, over 31% of the population. So for the people that are seeking treatment, we just have to accept that it's really, really hard to lose weight and keep it off. We've seen, when I was young, depression was considered, just get the black dog off your back, pick yourself up, get on with it. Stop being weak. But, there's been, a huge shift in stigma around mental illness over my career. And again, I think that started because, when we were at uni, we were taught that diseases occur in a biological, psychological and sociological setting. We started to understand, how brain chemistry can affect the sense of mental well-being. And we started to understand how we could treat it. And so there was sort of an empathy created through the profession. But then on top of that, we had some high-profile people who struggled with depression who were willing to come out and say, look, even me as a really successful person, Jeff Kennett came out and said, I was the Premier of Victoria and I had depression. That opens up conversations, and people who are living with those symptoms suddenly say, I'm not alone, I'm not the only one who feels this way. So I feel like we're a little bit at that tipping point with obesity at the moment. And I think it's partly because we now have more effective treatments. We've had bariatric surgery for a while, but surgery is confronting for a lot of people to think about, and drugs are a little bit more easier to sort of approach. And so the fact that we've now got GLP-1 agonists and then the GLP-1 GIP, soon there'll be some other medications coming out. Suddenly people feel comfortable asking the question, well, is this something I need to think about? Which I think is important, and hopefully it will, the recent commission recommendations will help to keep that conversation going.
So what are some of the recommendations that you love?
Look, I think measuring people rather than just doing their BMI is great. And I do love the concept that you're encouraged to talk to your patient and find out what this extra weight might actually mean to them, and not being confined just by, well, you hit this number, therefore you have this disease. It's understanding, what does this mean for this person that's sitting in front of me, and how do I best help them so that they can live the longest and healthiest life they can.
I love that.
I think it's great. I was at a conference last year, and one of the questions that, a room full of these amazing GPs and dietitians, and one of the GPs said, how do we bring up a conversation about obesity with our patients without them getting upset and offended? And that really hit me, that it was like, here are doctors, and Tash and I were talking about this yesterday, traditionally, I guess, we would see a doctor as someone who, they solve the problems and they know and they can fix. And some of these amazing people, they were struggling just as much as what the patients were struggling with.
Because they don't want to offend. They don't want to.
They don't want to offend people. But, we have uncomfortable conversations as doctors all the time. Like, we have to talk about sexually transmitted diseases, or we have to talk about... And, I think in some ways those conversations are maybe easier for some people because we have specific training on how to approach it, whereas in the past we haven't had that sort of training around how you broach something like obesity. And you don't want to offend your patient. Now, I work in the field and I know I've had feedback from patients that I offended them when I weighed them, measured them and said, okay, so how are we going to help you lose weight? And they've found that I was a bit abrupt and they were a bit confronted by the fact that I was just so matter-of-fact about it. And so it's challenging because it is such a nuanced condition and it does mean different things to some people. Like me being matter-of-fact with some people, they'd say, yeah, great, you're just treating it like you're treating my blood pressure. Yeah. And I appreciate that you
I would
let
love
me be
that.
frank.
I would love that. Just love
that other people feel that they've always been so stigmatised by or had so much bias against them from healthcare practitioners. Someone being direct with them was kind of, very challenging and hurtful. And I've reflected on that and it is hard, but I think my advice to people when they ask me is I think, well, we're doctors, we're here to help people. And so you just need to try and understand as best you can. And it's hard when you're seeing people in a quick turning around environment and it might be someone you've never met before. But just something as simple as, well, you're carrying some extra weight. Is this something you want to talk about? And
I love that.
And see what they say.
It gives the patient the opportunity to go, no, I'm not ready to talk about that. Or,
and when I've said to people before that I'm going to weigh you and they're like, I don't want to be weighed. Okay, that's fine.
Yeah.
Some of our members, we've actually said to them, when you're going to see your GP about a referral to a weight loss surgeon or something, don't tack it on at the end of your appointment for your prescriptions or something because,
Don't have it be your doorknob turner. As you're
walking out. Oh, by the way, can I have a referral to a weight loss surgeon? And especially if you've never even spoken to this GP about your weight before, it sort of requires an appointment to actually discuss and let it be something that is worth that discussion for the appointment.
Yeah, I agree. And, just by asking the question, that opens up opportunity to have a bigger conversation. And it may be that the GP says, actually, I'm not sure that, that's the right thing for you, but we can talk about these other things or we can do these tests or whatever. But it's a big conversation. But it's natural human behaviour. You leave it right to the end, the thing that you really want to ask. It's a bit like, when you want to ask someone out on a date or something, you go all around all the different questions till you finally get to the date.
Right at the end.
Right at the end.
That way you can run out the door if they say no.
Exactly.
That's right.
Yeah.
Oh, goodness me.
I think it's great. I think the way I see this going is that it is creating conversation. You see it on social media that it is creating conversation and some uncomfortable conversations as well, I think, for people. But I think we've sort of got a bit scared of those uncomfortable conversations a bit, and it should be all right because it makes us all, I think we all need to be able to look at the position that we take with our health and question whether, do I need to change my focus? Do I need to actually listen to what someone else is saying, even though I've never agreed with that particularly before?
I mean, I just think asking patients how this extra fatty tissue or how this extra weight is affecting their life is a door opener for such a meaningful conversation. I think that's a fantastic recommendation.
Look, sometimes someone's not going to be happy with it, but it doesn't mean you shouldn't try. There's not the right way there's not one right way. And we're all individuals with our own particular biology, our psychology, our sociology, all the things we bring to the table that make us unique. But just being willing to at least have a conversation is the start. And I think, agree as well, there's going to be people that really disagree with this commission finding. They're going to find things in it that they really dislike. And that's kind of the point, because as a society, if we lose the ability to debate, to disagree, as long as that disagreement and that discourse is respectful, hopefully things will, if we can disagree and debate and in a respectful way, then we can see real growth. We can see that we can say, oh, that's a good point. We didn't think about that. Or this is, so suddenly you start to see things escalate and change towards something really, really good.
Yeah.
But yeah, you're right, Damo. I think there's been a tendency lately that we don't disagree with each other. And if we do, it can be a bit disrespectful, and that's not helpful either. So
I agree. I think that these conversations it's very, very important. It's very important for people with lived experience to stand up and say, hey, I don't like whatever that they might read in the report, in the Lancet report, and let your it's completely fine to have those sorts of conversations.
It's okay to disagree with people, like you said, if it's done in a respectful way. There's nothing wrong with disagreeing with someone.
Sure.
It doesn't even mean you can't be friends anymore. It's something that I've talked to a few people about, just in different things that I'm involved with. I would say to my teams, if you disagree with me, tell me. It doesn't mean that I'll change but I at least want to know what you're thinking and what you're feeling. And one of the comments that I was reading on social media about the Lancet report, it was like, if it's not perfect, then why are we doing it? And I was sitting there reading that, thinking, we have to start somewhere.
Mm-hmm.
And, if we don't start now, when? And, okay, it might not be a perfect whatever, but it's better than what we had.
Yeah. The BMI has stood us well. It's been a great tool, but it's being used in a way that probably it was never intended to be used, as the sort of sole arbiter of a very nuanced condition.
Yeah.
And the fact that it led to barriers to healthcare, the fact that it caused people to be overdiagnosed, it actually...
Or not diagnosed.
means it's just not enough. But it was a good starting point. And this just builds on from it. At least it adjusted your weight for your height.
Yeah.
Whereas back in the olden days, they just weigh you. You could be 5 foot tall and weigh 100 kilos, which is obviously a different scenario to if you're 6'5" and weigh 100 kilos, So it was a starting point. It's time for that conversation to move forward and think about how we use it. Not abandon it, but how we use it differently and how we supplement it with, I guess, with the knowledge we've gained over the last 60 odd years to make it better.
Yeah, I think it's exciting times.
So what other exciting projects are on the horizon for you this year? Can you tell us?
Well, we've got a trial and I'll let you know about it when it's finished, just looking at how weight loss drugs go in people who previously had bariatric surgery.
That's amazing.
So we should be getting some results on that out this year.
Very exciting.
As I mentioned, we just published the first 5-year results from the Bariatric Surgery Registry. We're starting the PROMS project, our patient-reported outcome measures project, has been going for a while now, but Alyssa, who's our fantastic postdoc now, she just finished her PhD.
Oh, how exciting.
Which is really exciting. Alyssa's rolling that out and we're starting to get the first results in. And we're also really excited that we've got our consumer advisory group up and running. Yes. So thanks, guys, for your assistance with that. You're very welcome. Because we really want to see the registry data being used in a way that is useful. Most importantly, it's to the people who are seeking and having the surgery. And then I'm really reaching out at the moment because I know you're very keen on the idea of guidelines, Tash. We're keen to start seeing the data going into guidelines. So that's something I'd really like to develop this year. But, I'm a bit of a novice in that field, so I'm reaching out to some experts to see if they can help us.
Oh, that's exciting. I would love to know more, as I'm sure you'll let us know as
things progress.
It's so good. But it's a very exciting thing.
Oh, so I'm so fortunate to work in a field that's, it's so dynamic, particularly at the moment.
Yeah.
Thank you so much for chatting with us today.
Oh, it's a pleasure. Thank you for taking the time to come and see me again.